Well, thank you very much, Sages, for the invitation, for the session chairs. It's an honor to be here today. I'm going to talk about acute sleep complications. I'm going to try to keep it within the first 7 days because after that it's a different management. These are my disclosures. I have nothing to disclose regarding to this presentation. A little bit of overview. As we all know, and this has been said in many sessions already, sleep gastrectomy has become the most common procedure around the world. Around 60% of all bariatric cases are sleep gastrectomies. So probably if we're going to see a patient in the emergency room, it's going to be a sleep gastrectomy. Comparing sleep versus gastric bypass, the overall complication rate is around 3.5%. And the leak rate has been described as up to 2%. How do they present to the emergency room? With mild tachycardia, some epigastric pain, some hypotension, fevers, leukocytosis, and some sepsis. The diagnostic test, as you all know, the emergency room will always obtain an abdominal CT. It's very hard to get an upper GI at night. Initial treatment, NPO, IV fluids, IV antibiotics, and evaluate the patient if he needs to go to the OR or an endoscopic approach. So let's review this. So let's see if this sounds familiar. The calls always get at around 10:30 to 11 o'clock at night, right when you're ready to go to bed. The resident calls you, correct, and says like, Dr. Camacho, I have your patient that you perform a sleep gastrectomy on Monday, uncomplicated negative leak test, was discharged home on post of day 1, tolerating liquid diet. 18 hours later, she represented to the emergency room again with PO intolerance, abdominal pain, and low temperatures at home. Physical exam, awake, alert, mild abdominal distension, heart rate 116, blood pressure was a little bit low, temperature of 99, white count of 16, the day of discharge was 11. So at that moment, you start thinking, okay, was this the first case, second case, third case? Was something wrong with the staple line? Well, I don't know. But you ask the resident, so do you have any CAT scan? Do we know that this is a leak? And definitely the resident will tell you, yes, there is extravasation of contrast in the left upper quadrant, and I think that it's a positive leak. And you still guessing, are you sure about that? And he said, like, no, I'm here with the radiologist, and definitely there is extravasation. So I already called the OR for you, we're ready to go, and we need to take the patient immediately to the OR. So what do you say? Wait a minute. Let's reevaluate where we are. Let's see how the patient is doing. And I think that we should evaluate endoscopically. So the patient was scheduled for an upper endoscopy. As you can tell here, patient had a full upper endoscopy. You want to make sure there is no obstruction or kinking at the body of the stomach that can, prevent this area from healing. You can see here the gooey coming from that fistulous tract. And the patient underwent a double pigtail insertion and stent. The idea is to place the stent at least 2 or 3 centimeters above the perforation. You can mark the perforation and the antrum with clips. As you can see, the left upper clip will show you exactly where the perforation is. And then you're going to deploy a long covered stent, trying to go all the way down to the antrum above the GE junction. And then you will see it under fluoroscopy in a minute how the stent was deployed. You see the clips where the markings are, the antrum, the incisura, and the leak area, and then we're deploying the stent in the incisura, body above the perforation, and at the same time you can do an upper GI, you can shoot some contrast, and you see if you're fully covering the area in question where the perforation happened, that's at the GE junction, and the idea is for the patients to start taking PO as soon as possible. These are the pictures of the patient. You can see that the stent was placed way above the perforation. So unfortunately, the patient at night, and this is a patient who had the procedure done at 5 p.m., he felt like he was having a lot of pain, feeling that the stent was coming up, and the gastroenterologist took the patient back to take another look, and the stent was removed. But didn't tell anyone or the surgical team. So the next day, the patient was having more abdominal distension, more abdominal pain. One of our surgeons that was on call obtained another CAT scan, but as you can tell, there was no stent in the abdomen. So she was panicking, said like, well, what's going on? We don't have the stent. And when we called the GI guy, he said like, oh, I'm sorry to tell you guys, but I removed the stent. So the patient went immediately to the OR for diagnostic laparoscopy, washout. They saw the tip of one of the drains, and that was an external placement of the drain. So the patient did well, thankfully, you're gonna see the follow-up CAT scan. Now you can see there is contrast in the colon. You can see the double pigtails and the external drain. The patient remained with the drains for 7 weeks and was discharged home on post-op day number 5, doing well with no signs of any complications. So this is what we are recommending at my institution. If the patient is unstable, definitely you need to go to the operating room to do a washout, drain placement. If you can oversew the area in question, you can put a nomental patch, and if possible, if you can put a fitting tube in preparation in case that the patient cannot tolerate the PO. But I'm gonna focus on the right side, on the stable patient. Antibiotics, IV fluids, and of course, adequate drainage that can be done with the endoscope, with endoluminal pigtails, and the stent. It's very important that they perform an ultrasound at the time of the insertion of the drains, because then you can miss any fluid collections and that the patient will require another intervention after. So now that you can see that the endoscopic approach is the way to go, my chief of surgery said to me, I cannot imagine I was training you at Ohio State, you calling me at 11 o'clock at night that you're gonna do endoscopic treatment of a perforated gastric surgery. And I said to him, like, well, this is the way that we're taking care of this patient. So is it safe? Well, stents have been around for many years. This is not new, uncovered stents for cancer obstruction, then partially covered, and after that, we put the covered stents. So all the articles that I found, they talked about location, size of the perforation, time of healing, how many stents were needed to be replaced. So pretty much all of them concluded the same things. Patients present 90% within 7 days, good success rate up to 97%, cover stents are recommended, especially the lung stents, complete healing 2.8 months, migration, which is a problem, up to 15%, but now they're fixing the stents with the clips, so that has lowered the number of migrations. And one of the biggest complaints are nausea and vomiting on these patients, correct? And if you leave the stents for some time, you have to be careful. This is a patient who presented with a hematemesis after a stent placement 8 weeks after, and the patient developed an aortoenteric fistula, and the patient died because of this complication. So you have to be aware of this problem. So let's talk about pigtails. We were mentioning most of the faculty here talk about the double pigtail. Also has been around for the past 10, 15 years. It's one area is left in the cavity, the other one is intraluminally. The patients can resume PO intake very fast after stents are placed. This is a 3D reconstruction of a CAT scan. As you can see that there is a drain in the cavity on the left upper and the rest of the catheter inside the lumen of the sleeve gastrectomy portion. It's also good to find other areas. As you can see, they're shooting contrast here to identify another area where the patient needs to be drained for that collection. So again, looking at some of the papers that have been published, 5 to 10 to 15 patients, very small series. And as you can tell here, they have very good success rate, up to 95% number of sessions. If the patients migrate, especially in those big cavities, the double pigtails can migrate inside the lumen and can be lost. Time to heal, up to 128 days, but approximately 6 to 8 weeks is what I have seen in my experience. The endosuturing, something that you have to be definitely very an endoscopic interventionist. I think that the results are not very promising. This is a group from Hopkins, 5 patients, almost half of them required another intervention, laparoscopic approach, and stent placement. So it's not recommended that well. The overclip or the vescoclip, the Big Bear, this is another way to treat these small fistulas. This is 26 patients with an 80% success rate. So in the conclusion that I have, as you can tell, the first line of option for these patients should be endoscopic. The long stents, the double pigtail, I don't think that the septotomy works in the acute setting. The big scope clips as good. The overstitch, I don't think that has good results. The EVAC as well, this is something that I like to use in my chronic patients, should be recommended. So I think that you have to be careful, because when you have a complication, everybody's looking at you, your chief, your partners, your residents. They all want to wait what's going on and what's going to happen. So you want to offer this patient the best approach and the best results. And as you can see here, they have the best shooters, so you have to talk to your colleagues, your partners, about what to offer to these patients, because what you don't want to do is this. It's time to say, I'm sorry. Thank you very much, and I will take any questions.